Hi, my name is Tanya Seifen. I'm a licensed clinical psychologist and assistant professor in the Department of Psychiatry and Human Behavior at UMMC. I focus on children and adolescents. I provide psychological services on our acute psychiatric child inpatient unit at the Children's Hospital, but I also provide individual therapy, behavior management training, as well as comprehensive evaluations at our Center for the Advancement of Youth. We will be learning, or I will be talking about autism, understanding autism, common symptoms, myths about autism, as well as options how to assess for autism and intervention to treat it. Welcome everyone to my talk on autism spectrum disorder. My name is Tanya Seifen. I'm a licensed clinical psychologist and assistant professor in the Department of Psychiatry and Human Behavior at UMMC. I have a little bit more about me too. So background-wise, I received my PhD in clinical psychology from the University of Mississippi. I did my pre-doctoral internship at UAB in Birmingham, and while I was in Birmingham, I was also trained in leadership education in neurodevelopmental disabilities. I have about 7 years of clinical experience in working with children and their families, or children on the autism spectrum and their families. And at UMMC, I provide, on the one hand, psychological services to our children on the acute psychiatric inpatient unit, Free Circle, but I also provide therapy services, individual therapy, behavior management training, and comprehensive psychological testing at our Center for the Advancement of Youth. As part of this testing, I do offer autism evaluations at our Center for the Advancement of Youth, also called CAY. Today, I want to go over symptoms of autism, so for everyone to fully understand what autism means and what it might look like. I will be going over common myths, things that people believe about autism, and hopefully we can kind of clarify some of those. I will explain to y'all what to expect during an autism evaluation and what is just considered a screening. And then I will go into treatment options, because there's lots of options, and I think it's good to know what's there and what you can access and what you need in order to access those services. Before I fully dive into autism, I'm going to quickly talk about neurodevelopmental disorders, because autism is considered a neurodevelopmental disorder. These are disabilities that are associated with the functioning of the neurological system, the brain. Okay, common examples of neurological or neurodevelopmental disorders in children are ADHD, learning problems, learning disabilities, intellectual disabilities, but also autism. Often our children with neurodevelopmental disabilities or disorders can experience difficulties that affect their language and their speech, their motor skills, their behavior, their memory, their learning. And these symptoms can kind of evolve and grow as the child grows older, but some of these disabilities are permanent and remain, and autism is one of them. Okay, so we consider autism a neurodevelopmental disorder that a child is born with, that may evolve, but that is something that we consider that's nothing that just goes away. So what is autism? So in order to understand autism, I'm going to go over the two main categories of symptoms that we see in autism, and I'm going to try my best to explain each one of those. Okay, so on the one hand, in autism, we see deficits in social communication. And I'm going to explain what each one of these means in just a second. On the other hand, we not only see those deficits, we also see the presence of restricted and repetitive behaviors and interests. So when we talk about social communication and deficits in social communication, one to look out for, one that is a common symptom of autism, is deficits in social emotional reciprocity. So what that means is the ability to have a back and forth typical social interaction. So that means having initiating conversations, maintaining conversations, taking turns, letting the other person speak. Those are considered, that is considered reciprocity, the back and forth that happens when two people come together and communicate. So oftentimes we see deficits in that area. Another deficit can show up in nonverbal communication. So nonverbal communication is everything that is not what I'm actually saying. So my hands, and you will have probably noticed just watching me a little bit, I like to use my hands. Those are gestures, okay? So everything I do with my hands and my body are considered gestures. Facial expressions, that's how I show you how I feel about the situation. You can read on my face sometimes if I'm angry or upset or if I'm happy. And eye contact will let you know if I'm listening, if I'm tuned into the conversation with you. Oftentimes, individuals with autism struggle with nonverbal communication, not only showing it themselves, like using gestures, using facial expressions appropriately, making eye contact, but also reading it in other people. The last one in the social communication category are relationships. So these are deficits or difficulties in establishing and maintaining relationships. So making and keeping friends, understanding how different social contexts and social relationships work, and how to behave in different social contexts. So this is all about like social communication. That is one category of symptoms that we often see in autism. On the other side, we have the restricted repetitive behaviors and interests. So what that means is, on the one hand, repetitive motor movements. Sometimes we also call this in the autism world, we call it stimming behaviors, okay? These can be obvious behaviors, like maybe like a hand flap or rocking, but it could also be something like some posturing with the body, just like a movement that seems a little bit odd. But it can also be something that happens within the play. So not only the motor movements are repetitive, but sometimes also repetitive play. So just playing in a certain way, the same kind of movement, pushing the car the same kind of way, or pressing the same kind of buttons. It can also mean repetitive speech. So that would mean that this individual would repeat things over and over that either they have heard that you just said or someone else said, or things from like TV shows and movies, like entire dialogues, and it's very repetitive. It goes over and over. So this is all what kind of falls under the category of repetitive motor movements or behaviors. Another one in this category is the insistence on sameness, or sometimes we refer to this a little bit as like rigidity, like being very rigid in how things need to be done. I need my schedule, and it's always best if everything is according to the schedule. And if something changes in the schedule, it would be better to let me know way ahead of time to kind of avoid any kind of like tantrum or distress. Highly restricted and fixated interests are also part of this category, okay? These can be typical in nature or atypical. So sometimes when I say atypical, I mean these interests are very unique and most people are not interested in this. So that could be something like trains, car engines, ceiling fans, vacuum cleaners, and I see some, reaction like people are like, yes, that is, just an interest that someone might have because, that is just what I'm into and that's what I'm learning about. That's all I want to talk about. Okay, so usually when we have a fixated interest, that's all the person wants to do, talk about, and learn about. But we also sometimes have in that category, typical interests that are excessive in nature. So that would be things like, for like a school-age boy, nowadays they're all kind of, from what I've gathered, they're all into Minecraft and some of these games. So everyone would be kind of like, it would be typical for what the age group likes, or collecting Pokemon cards, but it would still be excessive in nature. That's all I want to do. I want to buy all the merchandise that has to do with it. I want to know everything about it, and I usually start all my conversations even with this topic. For girls, there could sometimes also be things that are very, very typical, like playing with dolls and Barbies, baby dolls, taking care of my baby dolls. So it might not even look at first like a restricted interest, but it's really the intensity with which the individual wants to do this and pursue this interest, and the inflexibility in doing anything else. The last one is unusual sensory interests and aversions. So on the one hand, seeking sensory input. So that could mean licking, smelling items, food, non-food items, touching, rubbing certain textures, inspecting things really close to my eye because it's very visually pleasing, looking at things off the corner of the eye. So those are sensory, we call those sensory seeking behaviors, because it's very visually, for in this sense, like the vision pleasing, but also like, you know, like rubbing things that would be like a tactile thing. So those are sensory seeking behaviors. But sometimes we also see sensory aversions. So that means being very particular about certain materials of clothes, only want to wear certain materials, or only eating certain foods because of the texture that some foods have, and not being able to handle the texture of certain foods, and also noises and sounds. And when I say like being sensitive to sounds, I don't only mean like loud sounds. I mean sounds that are sometimes even just that we don't even notice, like washing our hands and running the you know, like the hair dryer might be too loud for an individual with autism. So now I've gone over a lot of symptoms within these two categories, and the takeaway message is really that there is a broad range of symptoms, and they can look differently in each individual with autism. Okay, the constellation of those does not have to look the same for each individual with autism. Knowing one person with autism really means you know one person with autism. Okay, it's a spectrum, and it will look different within each individual. I also put on here, so for us, like the clinicians who diagnose autism, we use the Diagnostic and Statistical Manual, which is now on the 5th edition. Now it tells us we're using these two categories. On the previous edition, the communication and social piece were kind of pulled apart a little bit, and we also in the previous edition had a diagnosis that was called Asperger's syndrome. Okay, this diagnosis does not exist anymore in the newest edition of this manual. So children that used to be diagnosed with Asperger's would now fall under the umbrella of autism spectrum disorder. Okay, so if you would now present your child, we would not call it Asperger's, we would call it autism spectrum disorder, but we would specify the level, the functional level of the child, okay, or of the symptoms. So that means how much support does the individual require. So when we diagnose autism, so let's say we have enough of these symptoms to say this is autism, now we want to know what's the functional level of autism. A level 1 is someone who might require some support, but maybe not a lot. This could be someone who is like in the regular classroom, who just struggles like with initiating conversations, making friends, but who is verbal, can express themselves, and they might just need a little bit of help with like how to really get to know people, make friends, and read nonverbal cues. Level 3, in contrast, might be someone who requires very substantial support. So that could be an individual who has a lot of deficits verbally and non-verbally. So sometimes our children that are still non-verbal or really just use minimal functional communication, so limited words to really communicate with us, they might require a lot more support. So they would be a level 3. So this is kind of how this would look like. Once you meet criteria for autism, then the clinician would specify what level of support you need. And it's also, I would like to emphasize that we can specify even within each category. So I could be a level 1 in my restricted and repetitive interests and behaviors, but maybe a level 2 in my social communication. Early warning signs. So this is something that I thought would be helpful to put in here for everyone who has young children or who's not sure and wants to kind of pay close attention and has some questions. We do have some early warning signs, behaviors of concern. That does not mean that your child has autism if they show any of those, but this might be a good indicator to reach out to your pediatrician, primary care physician, and do a little bit more of a thorough assessment for autism. So on the one hand, regression of previously learned or achieved language skills. So a child that might be already babbling, saying mama, dada, ball, and all of a sudden we have silence, and these skills just don't come up anymore. So they stop using them. Lack of pretend play or even imitative play. So pretend play is something when you look at like toys that are being sold on the market, everything is kind of laid out for pretend play, like little toy kitchens, pretending to cook something, making food for other people, baby dolls, feeding your baby dolls, taking care of your baby dolls. All of this is pretend play. And oftentimes we see a lack or difficulty in pretend play in children with autism. Same with imitative play. So you modeling something as a parent and the child, they start at an early age, usually like 1.5, they start to imitate everything you do and play as well. So when you see a lack of this, this is maybe an indicator to at least reach out to your PCP and ask to have this looked at. Also, lack of pointing or following a point that someone else does. So when I say, little Jimmy, look, and I try to get little Jimmy to look over there with me, and he's not following my gaze. Or I say, look, the balloon over there, and he is just, or she is not following my point. But the same also like the child not pointing themselves to let you know what they need. You know, usually they point and say, look, like airplane or juice. When we have a lack of pointing, that could be an indication that we have some difficulty with our nonverbal communication, and that is something you might want to get investigated just a little bit more. Same with like response to name. And we do see that, you know, lots of kids don't respond to their names. That doesn't mean your child has autism, but if it's part of a, you know, bigger picture that there are other lacks and difficulties, this is something that you might want to discuss with your pediatrician. Prevalence, so that means how often is a child affected by autism? So I try to put the newest data that I have on here. So I added 2018, and we are now, according to the CDC, and I got this little graph from also Autism Speaks, autism affects an estimated 1 in 44 children. Okay? The CDC has been watching the prevalence rate, so how often it occurs in children, since 2000. They have been really closely monitoring this, and we're seeing a steady increase in this rate. So in 2000 it was 1 in 150. Now we're at 1 in 44. And that leads to the question, is this because autism is becoming more common, or are we just getting better at diagnosing it? And honestly, we don't have a clear answer to this. The research suggests that it is not only because we're getting better at diagnosing it. There's something else going on. It is becoming more common. I wanted to go over some myths, okay, because I think this is going to be really important, because there's so many stereotypes, misconceptions, things that people learn from TV and TV shows, and some of these have already been clearly dispelled, and people have said that's not true, but I just still want to go over some of those. So people have an idea, because sometimes you may have watched a TV show like The Big Bang Theory, and there's Sheldon in there, and you know he might be having some quirks, and you kind of like, okay, this might be autism. Or we had like a big movie was Rain Man, okay? But also you might know someone who has autism and you know what they are struggling with. And that sometimes that creates like these ideas and misconceptions of how an individual with autism looks like. So one big one is that ASD only affects males. Okay, this is not true. Girls have autism as well, can have autism as well, but the ratio is higher for boys than girls. So 1 in 4 ratio, so it's more common in males than females. But we've also over the years learned that autism looks a little bit different in girls, and sometimes it's harder to detect and stays more like undiagnosed, or it takes several years longer for girls to get the proper diagnosis because it's so much harder to detect. People with ASD are savants, so that kind of comes from the idea that, you know, when we watch these TV shows and movies, that someone with autism has this unique skill that they are really good at numbers and they just know things. Actually, that is something that really only applies to like a small number of people with autism. So about 5 to 10% within the population actually have these unique skills and abilities. People with autism flap their hands and rock their body constantly. Well, some of them do, but some of them don't. So this is really something, some repetitive body movements might look completely different from like rocking or hand flapping. And some individuals on the spectrum, as I've mentioned before, don't even have any repetitive body movements because you don't have to have each single symptom. It looks different in each person. People with ASD all have an intellectual disability. This is also not true because about half or 46% of people with autism have an IQ that's what we consider average or above. ASD is the result of harsh or cold parenting. So this is a myth that came about because back in the day when autism was first kind of coming around, there were lots of theories what is causing autism, and one theory was about like the refrigerator mom, that the mom was too cold and that was causing the child to have autism. This is not true, okay? And I just want to emphasize this again. The parenting style has nothing to do with autism, okay? You did not cause your child to have autism. Vaccines cause autism. No, vaccines do not cause autism. Okay, we've done so much research to really make sure people understand this is not related to vaccines. This was really some data that came out years ago, and people that put this information out, it was all misinformation. And lots of researchers have gone out to investigate this again and were able to show this is not true. It's not caused by vaccines. You can spot a person with ASD based on how they look. That really depends, you know, like maybe if you're really well trained and you notice like a body movement that looks like autism, maybe you are able to do that. But honestly, since autism is on a spectrum and can look so differently, how would you be able to spot this? The last one is that it's just a type of eccentric personality. That is something that some people might believe because of what they've seen on TV and how it is portrayed. But really for a lot of our individuals with autism, their symptoms can be very impairing and very distressing for them and their families. So this is not just an eccentric personality trait. Okay, so this was all my information on like symptoms and understanding autism. I'm going to move a little bit into assessment. So the nice thing is, or the good thing for all of us is that the American Academy for Pediatrics actually recommends that all children are screened for autism between their 18 to 24 month well-child visit. So if you have a child that falls in this age category or is already past it, within the last years at least, your child will have been screened for autism by their pediatrician. If you're not sure if your child was screened, you can always ask your pediatrician or primary care physician to screen them, or you can do the screening yourself online. In toddlers, the most common screener that is used at most offices and that you can download freely, available online, is the MCHAT-R. So modified checklist for autism in toddlers. Those are 20 questions that kind of try to get at some of these common symptoms that I've explained, and it will let you know if the score is elevated. And then you can bring this information to whoever is your PCP and discuss the next steps with them. Some questions, or a question on there might look like at something like, if you point at something across the room, does your child look at it? So what I was already saying, nonverbal communication, using gestures and pointing, that will be assessed. A screener, like the MCHAT, is just a screener. It's not a diagnosis, okay? It just tells you there's a concern. This is not a formal diagnosis, so from here, there are next steps that you would have to take. But it would be an indicator. If the screener says it does not look like autism at all, then you can probably take a deep breath, okay? If it says it does, then your pediatrician should be able to help you to make a referral to get your child formally evaluated for autism. So what to expect, or what is part of a formal autism evaluation, okay? So any kind of qualified medical specialist, such as a neurologist, a developmental behavioral pediatrician, a psychologist, psychiatrist, they're allowed to make these diagnoses, but very often what you will run into is that it is a psychologist who will do like the actual testing, okay? As part of the full evaluation, what to expect is this should last at least a few hours, okay? Because you will have an interview, you will have the actual testing, you might fill out some questionnaires, there will be a feedback, and in the end, ideally, you will get a report of everything that was done. And that should have this diagnosis on there, and then it counts. It's the clinical diagnosis. And with that, you can move forward to get started on getting services. Usually the interview would be like a structured clinical interview. I put a common one on there that takes forever, so not every clinician uses this one, but it's neat because it has all the symptoms on there, and it would tell the clinician if your child, according to you, the parent, meets criteria. The gold standard to assess for autism, it continues to be the gold standard. It's widely used across the country and outside of the country, is the ADOS-2, Autism Diagnostic Observation Schedule. And I'm going to go a little bit more over the ADOS in just a minute, so you know what it should look like and if your child has received one of those. Sometimes providers do not give this and still diagnose, and that might still count, but there's some places and some insurances that want to see the ADOS being done. Also, what we sometimes do during testing is some IQ testing, get an idea where the developmental level of functioning of the child is, cognitive level of functioning, and then you will be filling out questionnaires. Some of these are very specific about autism. Some of these might be more general behavior problems. While I'm talking about this, I also want to highlight there is a difference between a clinical diagnosis and an educational diagnosis. Okay? So your child can get tested through the school, and the school can say this is autism and give your child special education services, but this is an educational diagnosis. So this will not open every door yet for the services that you need. So you do want a clinical diagnosis done by a professional, like a psychologist, who has done formal testing, diagnoses it, and gives you documentation. Okay? Often what I see, and I'm being honest, is that in some schools we do not do the ADOS to diagnose autism. So sometimes what the schools would do is just a questionnaire. I would recommend to see a professional outside of school and have the full evaluation done, including an ADOS. And we now have another test that we've been using at our K clinic a lot, which is called the STAT. Which is also more like a screening tool, but a little bit more advanced than some of these questionnaires. So the ADOS allows the clinician to accurately assess and diagnose autism. What it looks like, it's like this huge box of materials, okay? And the ADOS is, we are already able to use this with toddlers. It has a toddler module, so your child could be like 1.5 or 2, and we could give an ADOS. And then module 1 to 4 usually looks like, is based on the language level of your child. So we start with activities that are for nonverbal children, and the more fluent the speech gets, the different activities will come about. It will provide the ADOS. These are play-based activities and conversational activities that the clinician will do with your child, typically during the toddler module or module 1. You, the parent, will be in the room. This is kind of indicated and required by the test, to have the parent in the room, because we will be using you as a tool for us clinician in the room to get your child to do things. Okay, so if your child is still young or nonverbal or limited verbal skills, you will likely be in there and you will be witnessing the full assessment. If your child is more fluent in their speech, then you will probably not be in there, and it will be more conversational skills and a couple of like play-based activities. I don't think I have like time to show you like specifically from the ADOS like what an activity might look like, but as an example, for a module 1, so this is a child that is basically nonverbal, but we also use it for module 2, that's a child that has phrase speech. We do, there's one activity that is called it's called like a birthday party for a baby. Okay, so we make a birthday party, we make a cake, we blow out the candles, we have the entire, kind of like the entire script down of what usually happens at a birthday party, and what do we do next, and how do we take care of the baby, and how do we feed the baby. And this is a really great activity to observe the child, how they handle this type of pretend play. Okay, so this will be the full evaluation. You will get a report, you will get a formal diagnosis. The diagnosis will open doors to get services, but you don't need to wait. Okay, so there's some services that are already available even if you don't have that formal diagnosis yet. So especially if your child is still very young, or if the school is playing along and they have done their work and they can get their services through the school, then you can get started on speech therapy, occupational therapy, sometimes some individual psychotherapy, whatever might be needed. But it might be hard to get into what we call applied behavior analysis, ABA, like the gold standard type of treatment that we really want. But you can, like I said, you can get started. Get your pediatrician to refer your child, get them enrolled in services. So while you wait on this formal diagnosis and you get on the wait list for treatment, you don't have to sit at, like basically have your child sit at home and wait. You can get them already started on things. So what does this really mean and look like, intervention? So for a child with autism spectrum disorder, lots of people and lots of professions will be working or can be working with your child. So you might be working with, let's say, a speech pathologist because your child needs speech therapy, because like I said, often we have problems with communication. That's something that can be worked on in speech. So you will be working with a speech pathologist. Sometimes children with autism struggle with sensory difficulties, motor skills, so you will be working with occupational therapy. So an occupational therapist is maybe someone who works closely with you and sees your child twice a week. Within the school setting, special education, a special educator, but then also we have psychologists who will be involved in the assessment, diagnosis. They are able usually to provide some kind of like parent training, behavior management training. Let's say you have a lot of behavioral problems with your child. This is something a psychologist can help with. A counselor can help with those things too. A psychologist can work on social skills. So if we have an individual who is verbal but just struggles a little bit with like reading social cues, this is something a psychologist can and will be working with. But also a lot of psychologists are board certified behavior analysis. So those are the people who do ABA therapy. And then a physician might be someone you will be working with, like a psychiatrist or a developmental behavioral pediatrician, someone who can help you navigate maybe some of the developmental delays. If you have a lot of like elimination, like potty problems, or a lot of like sleep problems, behavior issues. So sometimes it can you will be working closely with a physician as well. These are all the types of therapies, like I try to kind of connect it. So who does what? So a psychologist or therapist would be doing like cognitive behavioral therapy. The OT person would be doing occupational therapy. Medication would be maybe a psychiatrist. So there are lots of different treatments, and depending on the level of the functional level of your child. So as I mentioned earlier, we kind of specify 1, 2, 3. You might need different services, also depending on the age of your child. So I'm going to go a little bit more in depth over some of those. I want to highlight one more time early intervention. Okay, these are services that are available 0, like birth to 3, for children that have any type of developmental delays. These have the greatest evidence. Okay, so if you have concerns about developmental delays or autism and it's detected early, get your child involved with early intervention services. This could include speech, OT, or ABA. They can come to your home, or you go out in the community to see them. And the reason why I want to emphasize this is because of this. Okay, so early intervention, skill level, is all kinds of skills. We're talking about language skills, motor skills, play skills, social skills. Time is like over time what the skills look like. The yellow line is a typical development. Okay, typically developing child would show you like a trajectory of a yellow line. They would just keep going on over time learning these skills. The green line, this is what this often looks like in autism. Okay, so but if we come in early with early intervention, we can slowly close this gap a little bit. And the earlier we start, the better. Because the later skills build on the early skills. Okay? So if you target early and you work early on the basics, the language skills, the motor skills, the social skills, that will get you so much further for the skills that kind of add on and build on those skills. ABA. I do have a little video for this that I'm going to show in just a second. So ABA is what you probably would want to get your child enrolled in once you have a diagnosis of autism. Not every child with autism needs ABA. Okay? I'm also being honest, most places that offer ABA have an age limit. So after like 8 or 9, they might not even take any new patients. That doesn't mean that ABA does not work with children that are older than 9. It's just what most of the therapists, ABA therapists, what they are trained in, what they're kind of working on, the basic skills, target more the younger population. So ABA has been widely used since the 60s, and it targets a lot of different skills: communication, play skills, social skills, cognitive skills, self-care, learning how to use the potty, all those things. The ones in bold, communication and cognitive abilities, are actually the ones that we have the highest evidence for that ABA is really doing something for these skills. ABA means it's based on behavioral principles, so on behaviorism. How do we increase the behavior? How do we decrease an unwanted behavior? So it talks about reinforcement. So if your child shares their toy, you say, "Thank you for sharing your toy." Your praise, saying thank you for sharing your toy, that's a reinforcement. And that will increase the likelihood that your child in the future will share that toy more often. Okay? Same way, if we have an unwanted behavior and we figure out what the purpose of this behavior is, like let's say hitting, and we figure out why they hit, then we can either withdraw our attention or have consequences that will help us decrease this behavior. An ABA therapist will able to figure out what you as a family need and what skills you want to work on with your child, and they will break these down in small itty-bitty steps. So for us, I always like the idea of like brushing your teeth. Okay? Brushing your teeth is something that is so simple. I say, well, you just go in there, get your toothbrush, get it done. But what is really all part of brushing your teeth? You have to go in the bathroom, you have to find your toothbrush, you have to like open the tube, you have to put toothpaste on, you might have to like hold it under water, you need to be able to kind of turn the water on. There's so many steps. So ABA helps us break these down and teach the child step by step what to do. I'm going to try and see if we can watch this little video. It's a little bit older, but I think it really shows what is kind of done in ABA, okay? And I'm not an ABA therapist, so I'd rather have her tell us a little bit about this.
Applied Behavior Analysis. ABA stands for Applied Behavior Analysis. The goal of ABA is to teach children the skills that they need to learn from their environment. Basically, it's identifying specific behaviors and modifying them and keeping data on them so that you can tell what is changing. Well, let's count. 1, 2, 3. Who's in school today? Who's in school today? Who's in school today? Who's in school today? When you begin an ABA program, you assess the child and you identify different skills that you want to work on. A very important part of an ABA program is figuring out what's reinforcing to the child. So you would use a reinforcement assessment to determine what's going to motivate the child to learn. The more powerful the reinforcement, the more rapid learning will occur. I try and stay away from food reinforcement. I use computer. Most of my children love computer and they'll work for computer. They'll do anything for computer. I have one student who works for the piano. I have one student who works for puzzles. Well, he works for puzzle pieces. So as we're working, every couple of answers that he gets right, I give him a puzzle piece, and then when the puzzle is filled up, he can go and play with it. It really depends on the child. I have one kid that loves high fives. So, yeah, something as simple as that you could, it's more natural.
Turn the page. I saw a yellow dog looking at me. Yellow dog.
I keep data during one-to-one work and during their workstations. With 6 students, it's really difficult for just me and one paraprofessional to keep data on everything. I try and target specific skills that the students need during group activities and work on that individually. Let's see, today is number 19.
Up.
Find number 19.
Tuesday.
Find number 19.
Monday.
Find number 19. There's number 19. I'm concerned about what's going on at home. How can we teach your child things that are, that's going to make his or her life easier at home. Every week we take a trip to the supermarket. It's a very important trip because a lot of the parents in my class say that they can't go to the supermarket. They can't take their child to the supermarket because they pull everything off the shelves. They are running up and down the aisles. They don't know how to behave. This is a really significant thing to a parent. They need to be able to take their children out in the community and feel comfortable. So we take a trip to the supermarket every week and we learn how to behave, and we learn how to use money, we learn how to choose things. Here!
Usually so into it.
Say, I want to give them out.
I'll hand them out.
Here you go, Ted.
Cheese.
When a child is diagnosed with autism, the ideal situation would be for them to start ABA therapy as soon as possible. So whatever age that diagnosis comes, parents should start looking for therapy.
All right, so one thing that she mentioned briefly, or I don't think she really explained it here, is that ABA is very intensive, okay? So it's to do it really the right way, it could be like 25 to 40 hours a week. So sometimes in some states, the school offers it through the school because it will be part of the day-to-day, and that's kind of what her setting looked like. These children were part of the classroom. For us, usually what it more looks like, it would be several days a week for several hours that you would come, bring your child, and they would participate. This is not a treatment that they will be doing forever, but in the beginning it will be very intensive. Another type of treatment that I wanted to touch on is social skills training. So this is something that you don't have to have a diagnosis of autism for, nor do you have to get on a really long wait list. Usually most therapists, counselors will be able to work with your child on their social skills. Social skills are taught through a curriculum of social stories, explicit teaching, role-playing. So there are some nice actual curriculums and manuals out there that guide the therapist together with the child from the beginning to end, learning all the social skills that they need to have success. And oftentimes what they work on in social skills is really like getting better at expressing your thoughts and your feelings appropriately, like taking turns in conversations, initiating conversations, maintaining conversations, finding the right topics for conversations, showing more flexibility in social interactions. And often social skills training will break concepts down for the child or individual. So something that seems so simple to us, a social concept, might be hard for someone who has autism, so it will be broken down into concrete steps like what to do, and I have a nice example on the next slide for that. In social skills training, we can work on just like interpreting verbal, nonverbal communication. We can work on eye contact and facial expressions, reading facial expressions in others. This can, like I said, can be something that can be done by a psychologist, a counselor, any kind of therapist. Sometimes this can even be done in speech therapy. One program, this is more for teens and young adults, but it's a pretty neat program that is kind of has now I think they are not only national but internationally used, is the PEERS program, which stands, I think, for the Program for the Education and Enrichment of Relational Skills. It came out of California, but now we're using it about like across the state. It's a nice program for the older group who still struggles, has a hard time making friends, having get-togethers, or maybe even when we move into dating life. And so the PEERS program will work on those skills. So one example how we do this in social skills training is asking someone for their phone number. Okay, this is hard for everyone, asking someone for their phone number, asking someone to hang out and do something. So what are all the steps that we need to take to even get there before we can ask someone to give us their phone number? And social skills training usually breaks those down, where you have to have talked to this person several times before you can come out and just say, hey, can I have your phone number, or do you want to do this or that? Trade information, get to know them. You have to find a common interest with them. And once you know what they like, and you have something that both of you like, then you can use this as a cover story. You know, there's this new Marvel movie coming out, and I know you like Marvel and I like Marvel, so if I had your phone number, then, you know, when I know exactly when the show times are for the movie, then we could go. You know, maybe that could be a good way, once we find a common interest, then to see and ask for a phone number. Still, also it would teach like to assess interest. Once you make the suggestion, you know, do they look like they want to? And if they don't, you will have to back off. If they do, you can ask for the phone number. So those are things we can work on in social skills training. Other things that you saw in the video as well are visuals, okay? So we know that individuals on the autism spectrum really like or definitely process visual, concrete information better than just auditory information alone. So a good visual can always be helpful for all kinds of situations. We have visuals like as for schedules. So just having your schedule, this one is a morning schedule for the school, but you can do the same at home. Like, what is the routine or the expectation in the morning? Write it down. For a child that can't read yet, you might have pictures. For a child that can already read, they can write the words down, but it's a visual, it's right there, we can refer to it. And if you need to make changes, you can, like in advance, say, look, on Thursday, let's see, on this one it says, put away your backpack when you get to school, then there will be circle time, then we do math, snack, bathroom, and reading. Well, on Thursday we won't have math, we're going to be doing art. Okay? If you have a visual schedule like this, you can prep for this. You can kind of like point to it, like revisit it, and you can change these things out. Same with like social stories. Social stories are really nice, neat tool to help, I think, just about anyone, you know, not just an individual on the spectrum, but to help people through difficult, maybe anxiety-provoking situations, new situations. So there's something coming up, a dentist visit, and your child usually doesn't go to the dentist. A social story is something you could read every day for the entire week coming up to the appointment. You can prep them. You could have pictures, little descriptions of what to expect, so that by the time we're getting to the dentist, the child knows what the steps will be and what will be happening, and you're not just throwing them in there. PECS is also something that is more like for our individuals that have limited verbal skills, so that they can do some type of functional communication with you. They can let you know what they need. They might not have the words yet, but if you have these PECS, like these pictures of the activities and what they want, we can use a picture in exchange to say what we want. These are all neat tools. And any kind of therapist, counselor, a lot of speech therapists that I've met, even a lot of teachers that I've met, are pretty comfortable with those. So you can reach out to a lot of different professions and providers to get help with those. It's always also good to get some parent education, some training, get you some support. There will be challenging behaviors, behaviors where you're not sure how to manage them, to maybe improve the way you communicate and give instructions. A counselor, a therapist, a psychologist, they can work with you on those things. And these parent education or parent training could be something you can be doing while you're waiting on ABA therapy, but also a lot of ABA therapists will offer this for their parents as well. Just I'm basically at the end, okay? So we're almost done. Just a couple of resources, okay? So after your child gets diagnosed, Autism Speaks is always a good resource. Just they have a lot on there on the website. They have a 100-day kit for young children and school-age children. That's the first 100 days after you get the diagnosis, like things you can be doing, steps to take. National resources, there are things like the National Autism Center. They have information regarding best practices for children in the school setting, internet modules. So these are all things, hopefully your school will already have some of these available, know about them. Sometimes when I do an evaluation, I put a lot of these resources in my recommendations so that the family have it written down and they can share it with the school as well. Mississippi, local, Jackson area, we have now 4 places who offer ABA, okay? Our case, Center for the Advancement of Youth, we just started an ABA program. We're still very small. The ones a little more established are like Blue Sky or Growing Tree, or Canopy also offers ABA. There will be a wait list for all of those. Some don't, some only take private insurance. I know that Canopy does not only take private insurance, so I often also recommend Canopy for ABA therapy, but the wait is long. So once you get the diagnosis, get them on the wait list. You might have to wait a year. You might have to wait a year and a half. But in that time, we can do other things in the meantime. Okay, so a lot of kids, when they get detected early, I say, well, get them on this ABA wait list, but at the same time while you wait, let's go do speech, OT, you come for behavior therapy, we just do whatever else we can do to continue to work on all these skills that we want to increase. Mississippi, across the state, has centers and places like the big universities have, like Mississippi State has the Mississippi Autism and Developmental Disabilities Clinic. Southern Miss has a clinic. There are parent support groups. Some of these, like the Autism Center of North Mississippi, is in Tupelo, but they sometimes have virtual parent groups as well. So now that we all know how to use like Zoom and have virtual meetings, sometimes this makes this even more accessible for parents to join a support group that might be actually taking place in Tupelo. There's some books that we sometimes recommend. It's always good to kind of do your own reading. You can do this online, or you can maybe use a book, like for example an early start for your young child with autism, or a complete guide to understanding autism. Those can all be very helpful for you to really familiarize yourself with what's going on and what's available. And that was it, my last slide. Okay, what kind of questions do you have? I know it was a lot of information.
We have a 7-year-old that we've adopted. Psychologist says that he's not autistic. His pediatrician actually says she believes he is.
Okay.
He has a lot of the similarities with autism.
Yeah.
Things. One of the things is he has a lot of sensory processing stuff.
Mm-hmm.
Like food aversion, OCD, ADD. The problem though is if he's not autistic, you can't get an official diagnosis for sensory processing disorder.
Yeah.
Which puts us in a quandary as to the kind of help that he needs. I mean, he does receive OT, outside of school, but at school he does speech, and he's been referred to IEP for a group behavior, but that's as far as we can get.
Yes. Sometimes if you think there's more and you feel like the opinion that you got is not accurate, I would suggest to consider getting a second opinion. Okay? Just to make sure, like, have someone else look at the situation and see if they agree with the psychologist or if they see something else. Autism, and I'm being honest, is sometimes really hard to detect because if they are young and they have these very common symptoms, it might be easy to spot. But sometimes our older kids, it gets harder and harder to diagnose because they have already worked a lot on themselves. They have done a lot of treatment already, and a lot of these symptoms get a lot harder to diagnose. So sometimes it can help maybe to get a second opinion. But yes, you're right, like a sensory processing disorder is nothing that we have in our diagnostical manual for mental disorder. So it's not in the DSM that we use where we also diagnose autism. So it's kind of like a separate diagnosis that occupational therapy sometimes uses. So they would treat this. But I also don't know necessarily anyone besides maybe an ABA therapist who would be able to really target sensory issues. If it's mainly food, feeding therapy can be also an option. That will be done through speech therapy.
The only problem with that is that, he's high functioning, for sure. I mean, however, with his behavior stuff, they say that he was referred for an evaluation for feeding, but then the feeding therapist will not do anything because of his sensory stuff is off the chart.
Okay.
Pediatrician, even today, he had his yearly checkup. Pediatrician said, I still believe he's mildly on the spectrum.
Yeah. And honestly, I would probably recommend to get a second opinion. And sometimes I see kids and I say, well, I do see some autism, but I'm just not 100% sure. Just like the data is not really consistent. Or I want to see your child again next year. I want y'all to come again next year. Let's look at it again. Or get a second opinion. So sometimes that can be helpful if you feel like you don't have to. One evaluation is just one evaluation. Okay, so it's still possible that this actually is autism, and so maybe having someone else look at it can be helpful. Okay. Any other questions? Yeah, go ahead.
So it looks like there is a very simple line, very thin line between delayed development and autism. Doesn't exactly it's the same thing. Like in our case, our son, he has a delay in speech, and he had a delay in walking.
Yes.
And at some point they say that could be autism. Then they said that he can engage and he can look at you. But also he's trilingual. So then that brings more confusion.
Yes.
He hasn't been screened or diagnosed.
Yeah.
So I guess we will need to be referred to a psychologist first, and I guess I need to talk to the pediatrician about that. Can they get diagnosed more than once? Can I do it when not just two? Then let's say they don't find anything, but the delay persists. New signs come.
Yeah.
Can I do that?
Yeah. You can. it might be something that's really hard to detect or differentiate at this young age, and so you can have them reevaluated in a year or two. And yes, you can always do a re-eval, and they can get diagnosed twice. Obviously, what will be kind of like unhelpful is if you already have this established diagnosis, you've done everything you needed to do, and then several years down the road, after your child has gotten a lot of treatment, they don't, have the common signs anymore. They get tested again, and all of a sudden, the person says, "Well, I'm not really sure if it's truly autism." Well, you've done a lot of. At that point, you have that diagnosis. You've worked a lot. Yes, of course, we expect a lot of improvement. We've done a lot of work. So that would be kind of the only thing, to be aware of. But usually, yes, you can have them reevaluate. It's very hard to differentiate when we have children who have overall or like global developmental delays. And we do often see a speech delay in autism, so that's kind of like very close. So that is something, in the beginning it's hard to tell. But what they were probably trying to tell you, and what like one of the main pieces is that when even like when children are speech delayed, we would still want to see things like following a point, the social smile, imitating, tongue out, when you do the tongue out, playing with you, pretend play. They can still do those things even though their speech language is delayed. So that is sometimes something like the little nuances that kind of play into this. But yes, I would ask, if you're worried, ask for a referral to have them formally evaluated. At our case center, usually what we do is we probably have a dyad. That's how we call that, see the child first. So that's a psychologist and a behavioral developmental pediatrician. They see them together. They do like a screen, really look at the situation, an interview, and then they decide, do we have enough to then move further for like a formal evaluation. Okay? Right. Anyone else? Yes. Sorry, I think your hand was up. Yeah.
Is any of the therapies available for in-home therapy?
Yes, some are, and it really depends on what provider you kind of go through. I've heard about ABA being offered in the home.
Where would I start to look for that?
Yeah, it really like, if you live in the area, I mentioned like these 4 big places, and honestly, I think you will probably have to bring your child there. I don't know if they come to the home, if you're specifically thinking about ABA. Sometimes some early intervention, sometimes the speech pathologist or the occupational therapist will come to your home. We also have, when we just do general therapy, like individual therapy, working on social skills, we have some services where the counselors will come into the house. But most of the bigger clinics, the ones that offer ABA, I think they do most of what they offer in the clinic. So you would have to kind of call them and ask and see. I don't know of anyone in this area who does ABA in the home.
And then if my son came to the K clinic,
okay,
but my husband brought me home, like no paperwork or no, just they didn't die. What can I call?
Yes, you can call. You can call us at any time. If a formal eval was done and like a report was written and somehow that never made it to you, then they can just reprint and re-sign this and send it to you. If he was seen in like a dyad, like I mentioned, like by a team that did like a pre-screening and then they would be able to tell you that on the phone too. But usually if they felt pretty confident that that's autism, they would still give you documentation.
Okay. Thank you.
You're welcome. Yes.
Okay, going back to an example that you had earlier about the child running to the grocery store, knocking things off the shelves and things of that nature. How would a child like that get a disciplinary action?
So how you would like discipline this?
Yes.
Yes. But when we have kids that run up and down the aisle in the grocery store, I have a lot of questions because Our kids with ADHD do that a lot too. You know, they're very hyperactive and impulsive, and they can't hold their body still, so they shoot up and down the aisles as well. So this is not something that's unique or very, you know, specific to autism. Oftentimes, we actually work on the other end. So instead of punishing the behavior in the moment, we work on the appropriate behavior for the situation using reinforcers, as this ABA therapist was mentioning. What is this? What motivates this child? What are they willing to work for? And some kids, it can be very simple: a high five, a sticker, or maybe getting to pick one little snack in the store. And then you can do social stories. For example, as I mentioned, sometimes even go into the grocery store. There are social stories for that. What is appropriate behavior in the store? You will probably guide the child, you know, like into this activity. Ideally, I always recommend practice this. Don't try to expect doing your weekly grocery run where you buy all of your groceries for it to be perfect. If you are still practicing appropriate behavior in the grocery store, maybe pick a separate time where you just want to buy 1 or 2 items and you use this as a practice run. So you kind of discuss with your child, you know, hey, we're going to go pick up some milk. This is what I'm expecting from you in the store. You can kind of prep them for them, and then you can use whatever's reinforcing for your child to work for a successful move through the grocery store. And then you reward for this, basically. But that also means if I promised you that you can pick a snack and you ran up and down the aisle and pulled everything off, you're obviously not getting the snack, and then you have to be consistent, if that makes sense. Okay? Yeah, go ahead.
I have a question. So you said the
educational diagnosis?
The diagnosis is different. So when the psychiatrist at the school, there's just a screener, there's not a...
So when the psychologist, so sometimes the school has a school psychologist or a psychometrist work for them, and they do testing, but usually the school has educational criteria for autism. That is what they expect or need to see to meet criteria for autism in the school setting. So they do their testing very specific to that. If the child meets for this, they say, according to our school setting and the educational criteria, this is autism. Now we're providing services under the ruling of autism. But yes, this is not a clinical diagnosis. So that would sometimes insurance companies often would not accept this to get your child like into ABA, for example, outside of school.
And see, I asked that because recently, when I was working for the school system, they screened all the first graders for dyslexia.
Yeah.
And I found out that that's not, they don't even, you can't do that. And they tell them they have dyslexia.
Yeah.
But that's just a screen.
Yeah. And that's where it gets so icky, you know, because there's really a lot of stuff that's done outside of the clinical setting could be just a screener. And it's not really a formal diagnosis. And so I would always recommend, if your child is set up well in the school, getting services there, I would still recommend to pursue an outside evaluation for your own documentation so that you can get any other extra services that you might need. And,
yeah. I'm assuming pandemic is not helping our absence of social skills to be able to have socially adaptable humans.
No. I've seen and heard this a lot. So these are skills that we need to continue to work on. And what I've seen a lot is with the pandemic, with the virtual learning, it's like a decline. Okay, so these skills will also sometimes go back down again. Because if I don't socialize, and that even applies to our neurotypical functioning, like our kids that have a very typical normal development. Even for them, this is hard, but especially for our kids on the spectrum, because they just, oftentimes they're missing out at all the services that are provided through their IEP. They're missing out on all the social contacts, and they're oftentimes just sitting at home, and so these skills are not used. And sometimes I hear a decline even just in speech language. Just using words, putting together nice sentences. We see a decline there too. So yes, this has been very, very hard. That's why, especially with our kids with autism, I always say, if you can, bring it back into the school, okay? And if the school's open back up, use this. And it might be hard, and school is a very hard setting, but at home, isolated from everyone, you're not able to practice these skills either. So, yeah, tough times.
So I see there's a lot of information regarding symptoms and treatment.
Yeah.
But what information is available as far as the causes?
Causes, yes. So there's still ongoing research for this. There are definitely some genetic markers that are being investigated. We also now know that if it runs in the family, the likelihood is just higher. Okay, so there is a genetic component because we see it more often if it runs in the family. If you have like a cousin or uncle or someone with autism, there's a high likelihood that you have it too. And we often sometimes also see it in siblings, so that we have a family that have 2 kids and they both have autism. So there is a genetic component, but we can't really pinpoint and say this is exactly what it is. Yeah.
Our 6-year-old, she received the autistic grooming or the educational
at the school.
Yeah, but we've been to the K Clinic and other psychologists as
yeah.
well, and nobody is willing to diagnose her with autism. So, do you have any advice or any?
Yeah, and this is where I'm saying it gets so tricky because I've seen some of these evaluations that are done in the school, and I find them questionable because there was just a questionnaire, an autism questionnaire that the teacher filled out, and that was elevated, and now we're saying this is autism, and the school is putting this label on, and we don't have anything to back this up. And then the other side is also maybe the school is right, and they are the ones seeing it, but the outside providers don't see it because she's female, and maybe she is higher functioning, and she has some skills that are really masking and that are hard to detect. You know, like people are like, I don't know, is it or is it not? I would continue to fight for this in the sense that you don't give up hope, okay? You can always consider a re-evaluation, and you don't have to wait, like I said, for services just because you don't have the formal diagnosis. So maybe you won't be able to get ABA, maybe some doors are still closed, but you can still, you know, get her supports and services, like depending on what her skill level is. She might still be able to work with a therapist on her social skills. She might still be able to go to speech therapy or occupational therapy. So there's still things you can do in the meantime. Okay? Anything else? Yes.
My follow-up to the disciplinary question regarding the child. Spanking.
Mm-hmm.
Is it totally off the table? Is it like, have you seen, is it helpful in any way?
Yeah. Well, we run into 2 things with this. So on the one hand, actually a lot of our data and research is saying that we have better tools than spanking in general for our kids that are more effective, and that sometimes, depending on how the spanking is done, it can have negative effects on the child's development, or just kind of can be traumatic in of itself. Okay, so we have other strategies that usually if you come, most providers that you will work with will probably recommend for all children to use other ways of discipline and punishment than spanking. But something that I've definitely heard a lot, and this is like anecdotal, okay, is that families tell me that especially with our kids that have developmental disabilities and delays, it's really hard for them to understand and fully make this connection of why you are using physical punishment and to not react to this. So often here it makes the tantrum or the behavior worse. Or I sometimes hear that the child starts to hit back in the moment. So this is because there's like oftentimes, you know, for some children they don't fully understand what is happening, or it might not connect with the behavior that you're punishing, or they might see it as you basically hurting them, so they want to hurt you back, so they hit you back. So there's a lot going on with this. So I would usually recommend, if you have a lot of questions about like punishment and how to go about this, to maybe consult and like work with like a counselor or therapist who can go through some of these situations with you where you might want to choose spanking, and y'all can discuss if there's other options that would work better, and you try them out, and then it's up to you to kind of see, you know, what works better for you. I definitely tell all my parents, you know, I will be teaching you other skills, but obviously I'm not telling you you're wrong. You know, you are using the skills that you know, but I have some other skills in my toolbox, so let's see if some of these work. Okay? Does that kind of answer your question a little bit?
Just curious, what other tools?
Okay. So just as an example, we do really work on things like timeout, or taken away privileges. One treatment that we actually also offer at K for our younger group is parent-child interaction therapy, or PCIT. And in that treatment, we first work on the relationship between child and parent, but then we also work on discipline techniques in the room. And we have nice therapy rooms that are set up with a one-way mirror, and you as a parent, you get a little bug in the ear, and you are in the room with the child, and the therapist is behind the glass. And then we will teach you how to really do a solid, effective timeout. And we have a timeout room as well. We offer that, for example, at our care clinic as well, yes. And this goes up to age 7. After that, we usually have some other treatments available.
What's it called?
PCIT. And we actually, there's some research out there that this is also a good treatment for families with children with autism. So if you have a younger child, this can also be a very good treatment for you and your child on the spectrum. Okay. Any other questions?
Do you test kids in our house?
Yes, I do. But we have some other, like at our clinic, we have other providers as well that focus on autism. I think in Jackson itself, in the community, I don't know who really does a lot of autism testing. Maybe Dr. Jolly, I think, does some. But then sometimes people travel. Oh, you went with Jolly? Okay. Yes. And you know, you can always get a second opinion. And sometimes people travel for that too, you know. They go to other areas and places. But now that I went a little bit over like what to expect during these evaluations, now you know what you want to be seeing during an evaluation. So you can ask for it and say, well, I learned that, you know, like for example, the ADOS, this specific test that I mentioned, that is something that should be part of it. So you can ask for those things. Or ask even before you schedule the appointment. Is that something you offer? Okay.